Hi everybody, this is Dr. Abdullah from Dr. HE Clinic. Today in this video, I want to speak about gastric bypass surgery and novel methods on obesity surgery. As you know, obesity is a serious disease in worldwide, and in fighting with obesity, we have some tools. First thing which we do is changing lifestyle and the medical treatments and sometimes endoscopic treatments, and the most common are the surgical treatments last decade. So we have different options in surgical area to solve the obesity problem. Gastric bypass surgeries are one of these tools on surgical area. We have different types of gastric bypass surgery. Mostly in the surgical area, gastric bypass surgeries are known as Roux gastric bypass because the history of the Roux gastric bypass is very old. Around 50 years, the journey of Roux gastric bypass has been started around 50 years ago. So the experience on Roux gastric bypass is higher. For that reason, in the literature also, Roux gastric bypass is known as the most effective surgical treatment on weight loss surgery. If we look on those pictures, I want to define the digestive system in here. Our digestive system starts with the mouth and goes on with esophagus, and this is the stomach, which stores the food and drink, and the stomach goes on with intestines, and the absorption occurs in the intestinal area. We have around 5 to 9 meters of small intestine. This information is important to understand what's going on bypass surgery. In general, we can categorize the obesity surgeries in 3 different titles. First one is restrictive surgeries, second malabsorptive surgeries, and the third one is combined one. As you know, the most common one that we perform in our practice is gastric sleeve, and the gastric sleeve is the most known restrictive surgery. We can add laparoscopic adjustable gastric band also in this title. Only malabsorptive surgeries are not common nowadays. The combined ones, that is the title of today, are the gastric bypass surgeries. What I mean when I said combined surgeries, it is both restrictive and malabsorptive surgery. According to my definition on digestive system, on bypass surgeries, as you see in the picture, first we are creating a pouch on the stomach. We are dividing the stomach with staples and we are creating the pouch. So you can see 2 different types of bypass surgeries. One is Roux. The second one is OAGB. In other words, one anastomosis gastric bypass. It's also called as mini gastric bypass. What's the difference between? Especially the first part that I mentioned, the creating the pouch, are very similar in both surgeries. There is only a very little change in Roux gastric bypass surgeries. Surgeons prefer to create smaller pouch compared to the one anastomosis bypass. The difference between these surgeries is about anastomosis between the stomach and intestine. If we turn back to our definition, the foods are going through the esophagus and coming inside the stomach and going through the intestine. So, in the beginning of the small intestine, also the foods are meeting with the enzymes and the bile, which are needed for our digestion. For that reason, there is a difference between these surgical techniques about the connection. First, let me define the Roux bypass. In this surgery, after creating the pouch over the stomach by stapling it, we are starting to count the length of the intestine. When we reach the first meter of the small intestine, we are cutting, and also we are hooking up the distal part to the pouch, and we are making an anastomosis between the pouch and this intestine. So as a result, we changed the way the foods are coming through the esophagus, falling into the pouch and going to the new way. The remnant stomach and the beginning of the small intestine is bypassed by this Roux surgery. But as I explained, we need some enzymes and bile for digestion, and they are coming from here. For that reason, 1 meter distally to the first connection, we are combining the intestines for enzymes flow. As a result, the foods are coming here, enzymes are coming here, and the digestion starts distally from the second anastomosis. By this way, the patient is restricted about the amount of the food. This is the result of the pouch, and also the calorie is not absorbed totally by bypassing the remnant stomach and the first part of the intestine. A very little difference in one anastomosis gastric bypass. This technique is not older as Roux surgery. This has been performing in all around the world for last 10-20 years. So in this surgery, we are also creating a pouch with same technique, only some longer pouch, and then we are starting to count this intestine. When we reach second meter, we are making only one anastomosis with the pouch and intestine. We are using only one wall of the intestine in this anastomosis, and by this way the foods are coming through the esophagus, falling down the pouch and coming and going distally to the intestines. And also the enzymes are coming here and they are meeting with the foods here and they are going together distally. So as you see, there is only one connection in this surgery, and in Roux there are two connections. I can say that bypass surgeries are very effective surgeries on weight loss and also in the treatment of obesity-related disease. When we look at this table, we can say some things about the advantages. One, gold standard weight loss surgery, because very older technique and we know a lot of things about the results, pros and cons of these surgeries. And also good weight loss results. In the literature, it's mentioned that around 50 to 80% of the excess weight loss can be lost after bypass surgeries at the end of the first year. So this means an average loss of 5 to 8 kg per month after this surgery. And also by losing weight, we have some results about reducing the obesity-related disease. We can say these diseases as type 2 diabetes, hypertension, sleep apnea, hypercholesterolemia. These are very common in obese population. For that reason, when you solve the problem of obesity, these are the secondary results of gastric bypass surgeries. We can say something as these advantages of gastric bypass surgeries, of course. First one is vitamin mineral malabsorption. As I said, these are malabsorptive surgeries. So the first part of the intestine and most of the stomach are bypassed in this surgery. Some minerals and vitamins, especially iron, vitamin B12, and sometimes some electrolytes cannot be absorbed like before unoperated, cannot be absorbed as before surgery. So if a patient is conscious enough, this will not be a problem. The follow-up will solve this problem. We advise all supplements to all our patients, and according to the blood tests in the follow-up, we can give some recommendations about supplementation of needed vitamins and minerals. Another disadvantage that we can say is bowel complication risk. So in this surgery, we are also touching the intestines, sometimes some obstructions on the bowels, internal hernias. On these segments will be the problems after gastric bypass surgeries. But we should know that if we are speaking about an obese patient and if they have related diseases, the advantages are very higher than disadvantages of these surgeries. And also we should speak about the complications. First one is bleeding. The bleeding is the problem of all the surgeries, all areas of the surgery. There is a possibility of bleeding. We are closing all the vessels during the surgery. We are checking them all when we leaving the patient. But after the surgery, sometimes according to the change on blood pressure and patient condition, some bleedings may occur. The bleeding problem is easier when we compare to infective complications because mostly it can be solved with the transfusion of the erythrocyte suspensions and the blood component. And the rate of bleeding is very less. Inexperienced surgeons and inexperienced clinics, the rate of bleeding is less than 1%. And the second one, leakage and infection. As you know, we are making the connections here and we are creating a pouch. All the walls of the stomach and the connections between stomach and intestine are stapled, so leakages may occur in these areas. But as I mentioned, if the surgeon is enough experienced and the clinic and the team is enough experienced, and if the patient obeys the rules, and also the last thing, if the instruments are safer, the rate of leakage is less than 0.1%, and it's very less rate. And also the infections also associated with the leakage, and sometimes we can see some wound infections also with a very low rate. The third one we can say is blood clots. It's also associated with the patient's obesity. So some thrombotic problems in the deep veins and also in the intra-abdominal veins may occur after all weight loss surgeries according to the patient's mobility, patient's weight, etc. We should take care about this complication. There are some preventive steps on blood clots. We are starting all our patients blood thinners before the surgery, and we are going on these treatments 10 to 15 days after surgery. And we are giving anti-embolic sacs during the treatment on the hospital. And also we are trying to mobilize the patients earlier, very earlier, after 2-4 hours from the surgery. These are preventive steps from blood clots. You know, it's something known who should have gastric bypass surgery. In other words, I want to speak about indications. These indications are for all weight loss surgeries, but we should repeat them. The body mass index is the main concept on weight loss surgery indication. The BMI over 35 are indicated with weight loss surgeries and also gastric bypass surgeries. And also according to the recent guideline, patients with BMI over 30 who have related diseases or who are unsuccessful with the other methods will also be candidates for weight loss surgeries and gastric bypass surgery. And the second sentence is very important. Before surgical treatment, patients try unsurgical treatments in the fighting with obesity. If there is a failure in losing weight with only diet, exercise and medications, also these surgeries are indicated. I want to add something, especially in the Roux gastric bypass surgery. It's something special to Roux. This technique is higher in patients who have reflux symptoms. Reflux is something which is uncomfortable and which reduces the quality of life in most patients. If a patient is suffering from reflux symptoms, we should prefer certainly Roux-en-Y bypass, because according to the connection between the pouch and the intestine, and also according to the diverting the enzymes and bile distally to this connection, the pressure is always through the distal side of the intestine. For that reason, the reflux of the acid to the esophagus is very unrare in Roux-en-Y gastric bypass technique. So this can be said as another advantage of this technique. Mostly, both of these surgeries are very effective on obesity-related disease, especially in type 2 diabetes. We are preferring to perform bypass surgeries instead of gastric sleeve surgery in our practice. And as a conclusion, I want to say that together with a weight loss surgery performed on conscious patients by experienced surgeons and with appropriate indications, live longer, have a reduced risk of cardiovascular diseases, experience less obstructive sleep apnea, and also the joint related problems, and improve your quality of life. Thank you very much for watching this video. Have a healthy life.